Good afternoon. My name is Tessa London Bounds, and I am an assistant professor of cardiac surgery at the University of Kentucky. I have the distinct honor to moderate our webinar discussing infectious disease and infectious endocarditis, particularly tricuspid endocarditis, and our multidisciplinary approach thereof. We are hearing today from three extremely distinguished physicians on the subject with three very distinct perspectives. Dr. El Dalati is our infectious disease expert. We have Dr. Retta, who is a cardiac surgeon, a professor of cardiac surgery at the University of Kentucky, and Dr. Gurley, our interventional cardiologist, who's also a professor at the University of Kentucky. Compared to left-sided endocarditis in the United States, there's a paucity of information of right-sided endocarditis and treatment thereof. Right-sided endocarditis accounts for about 5 to 10% of all infectious endocarditis. And is more associated with IV drug abuse, cardiac catheterizations, as well as cardiac devices. There has been an increase in incidence over the last 20 years of right-sided endocarditis, and an alarming number of patients who are young in the 25 to 44-year-old range, with an astoundingly increased mortality of these patients. We at the University of Kentucky take an interdisciplinary approach for infectious endocarditis, and we wanted to share our approach as well as our contemporary data for treatment of tricuspid valve endocarditis. We will start the webinar off with Dr. Sami El Dalati. Dr. Sami El Dalati is currently an assistant professor of infectious disease at University of Kentucky. He graduated from The Ohio State University College of Medicine, after which he completed a joint residency in internal medicine and pediatrics. This was followed by a fellowship in infectious disease. During his training, he helped create a team approach to improve the care of patients with infective endocarditis. He is now an assistant professor of medicine at the University of Kentucky, where he is a director of their multidisciplinary endocarditis program. We have the distinct honor of including him in our webinar series today. Welcome, Dr. El Dalati.
Thank you so much for having me. I'm excited to be here. So much so that I'm missing the Ohio State game that's going on currently to be here and present. So
we acknowledge and appreciate that.
Thank you. I'm going to talk a little bit about medical management of isolated native tricuspid valve infective endocarditis utilizing a multidisciplinary team. I have no disclosures. So Dr. London touched on this a little bit, but in terms of the epidemiology of endocarditis in the United States, the most recent data suggests there's about 40,000 cases per year in America. In-hospital mortality is approximately 11%. But as Dr. London alluded to, over the last 10 years, but really even just going back the last 20 years, the proportion of endocarditis caused by injection drug use has increased substantially from in the early 2000s, 16 per 100,000 to up to 22 per 100,000 by the mid-2010s. Right-sided endocarditis accounted for, in this study, about 11 to 12% of all cases. And I wanted to just share a little bit of data about our experience here at the University of Kentucky. As some of you may know, Appalachia has been particularly hard hit by the opioid epidemic, and our cases of endocarditis at the university really reflect that. So this table is from a paper that we published in 2023 that looked at the epidemiology of endocarditis at our institution over a 10-year period. It's broken down into 5 two-year cohorts. So period 1 was 2009 to 2010. You can see there were only 86 total cases of endocarditis in that period, and a little over a third were caused by injection drug use. You fast forward to 2017, 2018, that number had skyrocketed to 505 cases of endocarditis, and 3/4 of them were now being caused by injection drug use. So you've seen an 11-fold increase in the amount of drug use-related endocarditis. And not surprisingly, we've seen an increase in our rates of tricuspid valve endocarditis. So again, going back to that 2009-2010 period, about a quarter of all of our endocarditis was isolated tricuspid valve. That number increased to 2017, 2018 to 41%, but just as a sheer number, we're looking at 209 cases now because of the total the explosion that we saw in endocarditis. So what are some things that make tricuspid valve endocarditis different as we think about our approach to management? So big one is the lack of systemic emboli and the absence of a PFO. So if a patient embolizes from a tricuspid valve, it's going to go to the lungs. Patients are able to tolerate those types of embolic events much better. There's not going to be the significant disability that might come with a stroke. The hemodynamic changes from severe tricuspid regurgitation are better tolerated than those associated with severe aortic or mitral regurgitation, particularly in young patients. Patients who use drugs tend to be on the younger side. And the overall mortality for right-sided endocarditis is more in the 5 to 10% range compared to 25 to 35% for left-sided endocarditis. Additionally, there are no FDA-approved valves designed specifically for the tricuspid position. Currently, valves designed for the mitral valve are utilized when surgical management is adopted, and I'm sure Dr. Retta will touch more on that. We've seen reports of premature valve failure, particularly in bioprosthetic valves in younger patients. And then mechanical valves require long-term anticoagulation, which can be a challenge in younger patients, and particularly those who use drugs. And then the big one that I think everyone is concerned about is the risk of reinfection if you go in and operate and someone continues to use substances. Just to touch a little bit on angiovac or percutaneous mechanical aspiration, part of what informs our management strategy is some internal data. So angiovac is, as many of you are probably aware, a procedure to go in and aspirate the vegetation. This is a percutaneous procedure using a suction device through a catheter-based approach. And so there's been a lot of popularity in trying to adopt this strategy, but there's not been a lot of data about how the management strategy of using angiovac compares to medical or surgical therapy. So we actually went back and we looked at our internal data. We published this study earlier this year looking at comparing medical therapy versus valve surgery versus angiovac for tricuspid valve endocarditis. What we found, as you can see here in the data, was that there was really no substantial mortality difference at 30 days or at 1 year for patients who received medical therapy, PMA or angiovac, or surgery. This was a Kaplan-Meier curves from our study. You can see there was no difference in 1 year mortality between the three groups. So seeing this data, this started to change our mindset a little bit and encourage us to think about, well, if there's no difference, perhaps the least invasive strategy may be the best option. I apologize, the animation is not working on this format, but this slide is to highlight that multiple organizations now have endorsed the role of multidisciplinary endocarditis teams in caring for this patient population. So on there's the American Heart Association, the Society of Thoracic Surgeons, and the European Society of Cardiology have all have formal recommendations that large tertiary care centers should have these teams as they care for this patient population. And I want to just highlight the 2023 European Society of Cardiology Endocarditis Guidelines. It's a great document. It came out about a year ago. Provides a lot of nuance in terms of the composition of these endocarditis teams, how they should function, and notably gives this class 1 recommendation that diagnosis and management of patients with complicated endocarditis should be performed at a heart valve center with immediate surgical facilities and an endocarditis team to improve outcomes. And just further supporting that recommendation, there was a recent meta-analysis that was published in Open Forum Infectious Disease, also in 2023, included 18 total studies in the paper, 15 were in the meta-analysis, but demonstrated that there was actually a mortality benefit in favor of a dedicated multidisciplinary endocarditis team. And the majority of studies showed increased rates of surgery and decreased time to surgery after implementation of these teams. So here at the University of Kentucky, we have a multidisciplinary team that helps to manage these patients. It's comprised of a number of specialties, as you might expect. So 3 of them are represented today: cardiac surgery, cardiology, infectious disease. But we also have our ACEs team, which is Addiction Consult and Education Service, neurology, neurosurgery, palliative care, pharmacy, even physical medicine and rehab, ethics, social work. So it's really multidisciplinary and interdisciplinary. We have nurses, we have social workers, we have advanced practice providers, all a part of this group. So our team started back in July of 2021, and we've been meeting now for a little over 3 years. We meet by Zoom on Wednesday afternoons, and since we started, we've presented over 550 patients. So you can see there really hasn't been a let up even in these last couple of years in terms of the large volume of endocarditis that we're seeing. One of the unique things that we did was we created a standalone ID consult service that just sees this patient population. It's staffed by an attending and an advanced practice provider. We have support from a nurse navigator, social work, and a pharmacist, and we all round together every day. We see all the patients. And this allows us to try to take a more standardized approach and have some more continuity in the approach to patient management. You can imagine at a large center, if there's 30 different ID faculty that are seeing these patients, you might get 30 different opinions about the best way to proceed. And one of the things we've also adopted is a multidisciplinary outpatient clinic that is a conjunction between infectious disease and cardiac surgery. So we formally do this 1/2 day per month, third Friday of the month. But additionally, since we have the infrastructure, patients will be added on ad hoc that we'll try to see together. So Dr. Retta and I see patients together almost every week. It allows patients to see both providers at once, and then it's kind of become the primary clinic for patients who have complex endocarditis, maybe don't quite meet surgical indications initially, but they need to be followed closely, and so we bring them back to be seen in that clinic. So our approach to endocarditis has been informed by our own data, our own clinical experience. So we recently published this review article in Therapeutic Advances in Infectious Disease. I encourage you to check it out, but I'll give you a brief overview here. And we entitled it Acute Drug Use Related Native Tricuspid Valve Infective Endocarditis, a Non-Surgical Disease. And in here, we outline the algorithm, our approach that we take here at the University of Kentucky. So once the diagnosis of tricuspid valve endocarditis is made, we make sure our infectious disease endocarditis service is involved, and then we get our multidisciplinary team involved, and we'll present the patient at our weekly conference. If the patient does have substance use disorder, which is the vast majority of these patients, we get addiction medicine involved right away. And then this is a key one. So for patients who are persistently bacteremic for greater than 48 to 72 hours, we evaluate for other potential sites of infection. But particularly in patients who have Staphylococcus aureus bacteremia, which is, again, the most common pathogen in these tricuspid valve cases, we will aggressively start combination antibiotic therapy. So for MRSA, that's usually daptomycin and ceftaroline. For MSSA, that's typically anti-staphylococcal beta-lactam like cefazolin or nafcillin with ertapenem. And in an effort to try and clear the blood cultures, because often that tends to be the thing that's going to push people towards doing an angiovac procedure or thinking about surgery, is that you can't clear the cultures. If we cannot clear the cultures, then we'll have a multidisciplinary team discussion about the risk benefits of proceeding with angiovac. If the patient clears, then we'll proceed to try to manage them medically. This is just some brief data on the combination antibiotic therapy. This was a randomized controlled trial from a few years back looking at daptomycin ceftaroline versus standard of care for MRSA bacteremia. The study was actually stopped early because so many more patients died in the standard of care arm compared to the daptomycin ceftaroline arm. So unfortunately, it didn't meet kind of the statistical power to make a significant conclusion, but you can see the trend here was quite concerning. And some additional multi-center data has suggested that patients who are started on daptomycin ceftaroline within 72 hours of their diagnosis of MRSA bacteremia tend to have a better clinical outcome. So that's the rationale for this. And we've had similar experience with the MSSA patients, as I mentioned, with this combination therapy with rapid time to clearance and improved hospital survival. So again, if the patients have cleared their cultures, we'll continue medical therapy, and then we'll also evaluate them for transition to partial oral therapy based on an internal protocol we've developed, which is heavily based on evidence-based strategy that was outlined in the POET trial from New England Journal a few years ago. And then ultimately, all these patients will be followed in our multidisciplinary clinic to assess for hemodynamic indications for surgical tricuspid valve replacement. So this is RV dilation or symptomatic right heart failure that's developing. And we're also taking into account where are they at with their substance use disorder? Are they in a place where they're going to be able to avoid injecting those types of things? And then we also talk with them very closely about, are they able to take warfarin or not, as we decide which valve to give them. So using this approach, we actually went back and we looked at our data with this algorithm, and we recently published also as a kind of companion piece in Therapeutic Advances in Infectious Disease, our management strategy. So we looked at about 2.5 years worth of patients from our own internal registry, and we had IRB approval, of course. You can see large number of total patients, 414 with suspected endocarditis, and we whittled that down to 72 patients with isolated native tricuspid valve endocarditis managed by our team. You can see some of the patient characteristics. The things to highlight here: the young age, the median age was 34, the high rate of Staphylococcus endocarditis, over 82% were Staph aureus. And then you can see injection drug use and substance use disorder were very highly represented. Over 97% of patients had substance use disorder. And what we found in those 72 patients, 66 were managed medically, so over 90%. We had 5 patients that did undergo percutaneous mechanical aspiration, less than 7%, and then just 1 surgical intervention. But notably, over half of patients had indications for valve surgery. And you'll also see over half of patients were transitioned to oral antibiotics. And in terms of our clinical outcomes, they were excellent. Our in-hospital mortality was very low. We just had 1 death in a patient who had a prior patient-directed discharge and came in multisystem organ failure. At 90 days, we only had 2 total deaths, and that additional death was in a patient with refractory leukemia who unfortunately passed away from complications of that. And then at 1 year, we had data available for 60 patients. We had 5 deaths, so still single-digit mortality, which is about what's estimated in hospital, and this is what we had at a year. And so we were very encouraged by these outcomes and wanted to get that data out there. You can see we still had high rates of patient-directed discharge, unfortunately, about a quarter of patients. And then we had about a quarter of patients who had no follow-up with our institution, as well as about a quarter who were readmitted. So we still had challenges in terms of the follow-up with this patient population. So, the take-homes here that I want to highlight, there's really no data demonstrating the superiority of Angiovac or this percutaneous mechanical aspiration to medical therapy. And in fact, the data that we have suggests that there's really no significant difference. Using a dedicated multidisciplinary endocarditis program with structured follow-up algorithms, patients can be effectively medically treated for native tricuspid valve endocarditis with very low rates of in-hospital and 90-day mortality, and moderate rates of delayed tricuspid valve surgery. We were able to bring back over a dozen patients to have delayed surgery in our study. But then despite the presence of this collaborative team, there are still substantial rates of patient-directed discharge, readmissions, and patients not seen in follow-up. So clearly some work to be done in terms of trying to improve the long-term management. So with that, I'll conclude. I know I went a little bit over, but a big thanks to ISC for having us, and then in ICS rather, and then to Dr. London for putting this together, as well as Dr. Gurley and Dr. Retta for being here. And if people have questions as well, feel free to shoot me an email.
Thank you very much, Dr. Eldelati, for that extremely interesting perspective. I've written down a bunch of questions, so I think that if we get a chance to have a Q&A session, we'll be able to address some of those. We will follow that up with our cardiac surgeon, Dr. Retta. Dr. Retta is a professor of cardiothoracic surgery at the University of Kentucky and is the current director and head of the cardiac division of the cardiothoracic surgery department. After completing his medical training at the American University of Beirut in Lebanon, he completed his general surgery training at the State University of New York at Stony Brook. He then completed his cardiothoracic surgery fellowship at the University of Texas branch in Galveston, Texas. He's currently double boarded certified in both general surgery and thoracic surgery, and is an adult cardiac surgery, doing the gambit of cardiac surgery, especially complex endocarditis. He is the main person in Kentucky who does homografts on our patients who have endocarditis, and he's an active member of the MDET, or the Multidisciplinary Endocarditis Team at the University of Kentucky. He'll be giving us a surgical perspective on the management of tricuspid valve endocarditis. Thank you for participating, Dr. Etta, and welcome.
Thank you, Dr. Londa. I appreciate the introduction. And thank you for attending this webinar on a Saturday, and appreciate the International College of Surgeons for organizing this. The title of my short talk is "Why do surgeons avoid the tricuspid valve in endocarditis?" And if you look at the field of endocarditis and the indication and the guidelines to surgically intervene, you'll see that over the last 10 years, whether it's left-sided endocarditis or right-sided endocarditis, there has been change in the indication. And multiple societies have different criteria for intervention, and that tells you that there is no right or wrong answer. And most of these guidelines are guided towards the left-sided lesion, and by analogy, we carry it to the right-sided lesion. I start by saying I have no disclosures, and I'm going to put this piece of literature to say that our approach and our experience here at the University of Kentucky is probably in 180 degrees difference with the more recent literature coming out of other centers, especially what presented in the American, on the AATS in April of 24, that showed that early intervention on tricuspid valve endocarditis was safe and was recommended. Why is that concern? Why am I concerned as a heart surgeon about tricuspid endocarditis? First, elements related to the cardiac anatomy. In the analogy between endocarditis and malignancy, there are limitations to the available prostheses used to reconstruct the valves after resecting the infected material. There are challenges innately present in any cardiac surgery related to the nature of cardiac surgery itself. And endocarditis is always full of pleasant and unpleasant surprises when you go to the operating room. And there are challenges related to the patient themselves and the substance use disorder that they come with. And that's basically underlying in almost every tricuspid endocarditis case that we've seen over the last years. Starting with the anatomy, I'm not going to touch on every point of that because a 10-minute presentation will not allow me to do that, but I'm going to touch on some of the important points. Starting with the anatomy, first, topography of the base of the heart, where most of the valves are anchored, shows you that the tricuspid valve sits in very close proximity to the aortic valve and to the mitral valve. And any infection in any of these valves can spread to other two valves. Plus, if you look at the tricuspid valve also is anchored along the right atrioventricular groove where the right coronary artery passes. And the tricuspid valve also has a strange relationship to the aorta and the left ventricle, because the level of the tricuspid valve is the lowest on the heart compared to the other valves, which makes the ability of any infection in the tricuspid valve to fistulize either to the aorta or to below the aorta into what we call the left ventricular outflow tract, or the other way around. Any infection in the aortic valve can fistulize to the tricuspid valve, whether the infection involves the subannular part of the aortic valve or the infraannular part of the aortic valve. If we look further inside the anatomy of the right atrium, we see that the tricuspid valve, where it say SLTV, the septal leaflet of the tricuspid valve, is in close proximity to where the conduction system of the heart lives. So infection in that area can cause and spread to the area of the conduction system of the heart, particularly the AV node and the bundle of His, and lead to heart block. And even if the infection does not spread there, if we anchor any prosthesis in that area, and even if we don't injure it by suturing or by cutting, just the mere weight of the prosthesis can cause a stretch on the tissue. And that tissue is very sensitive and can lead to this permanent dysfunctional tissue and adds the need to use a permanent pacemaker on a patient who has a prosthesis on the right side. And that has its own set of challenges and technical challenges on the long term. Now, when we say there is analogy between endocarditis and malignancy, this is a patient. I'm going to show you 4 images of patients that are presented to us with tricuspid endocarditis. And these are snapshots of their CT scans at the level of the left atrium. And then I'm going to show you another snapshot at the level of carina. The analogy is that we have the disease itself and we have the distant spread, which is the embolic event. And we see that the lung tissue is almost completely replaced with septic emboli that have evolved and regressed into abscess cavities. And we go in and you think there is a possibility of intervening on the valve and forgetting about this infected tissue inside the lung will lead to immediate infection of your prosthesis that you put in. This is the same patient at the level of the carina. I just took these 2 snapshots to show you that the entirety of the lung tissue is replaced with infective material. Same thing, another patient at the level of the left atrium and at the level of the carina. So regardless of what's going on in the heart of this patient, there is nothing that we can do surgically that will be able to help this patient, because the pathology now became pathology of the metastasis of that infective material into the lung, regardless of the primary lesion in the tricuspid valve. Now, let's say we don't have a lung issue and we have to go in and work on the valve. The spare parts are consistent. We use the spare parts available to us that were manufactured for the left side of the heart. There is no valve on the market today that was designed for the tricuspid valve. There is one that's being used under a trial. It's in its early phase to be used in patients, but it's not available commercially. And I think it's still way few years from being available. If it's going to be available, the jury is not out yet. What do we need when we work on the valve? If we repair the valve, we might need to patch it or use rings to basically support the annulus of the valve so that it supports the repair we do on the valve. And that's most of the time is not the case when you deal with the tricuspid valve endocarditis. The other options are prosthesis to replace the valve in entirety. It can be mechanical or it can be bioprosthetic made from animal tissue. The mechanical are made from pyrolytic carbon. We call it mechanical. It's really made from carbon. The mechanical valve need anticoagulation for life, and the bioprosthetic valve has a limited lifespan. And we'll touch on that briefly later. Now, when we go into the operating room, that's basically most of the time where you're going to see the expression on our face, because there is always more than what you seen on the imaging. The imaging does not catch everything that's happening on the patient. Even the TE intraoperatively does not catch what you see on the patient. So to summarize in a short presentation, what can you find in intraoperatively? That's the expression on our faces. The surgical treatment is simple. You have to cut every infective material. Again, the analogy between endocarditis and malignancy. In surgical oncology, you go in and remove all the tumor material. In endocarditis, for it to be successful, you have to go in and resect all the infective material, regardless whether resecting these material will compromise your ability to preserve the valve or repair the valve. You have to remove the infective material. Otherwise, plan on coming back and reoperating on this patient extremely soon. What are the mechanical? This is an example of a mechanical valve and tissue valve. Like Dr. El-Dalati touched on that, these valves are made for the mitral position. There is no valve designed for the tricuspid position. The one on the left-hand side of the screen is the mechanical valve made from pyrolytic carbon. In the mitral position, the recommendation is to use Coumadin for an INR between 2.5 and 3.5. We really don't know in the tricuspid position what's the best INR. There is less pressure gradient, there is more flow across that valve, but there is less pressure gradient across that valve, and there is more turbulence on the right side than the left side. And at the site of turbulence, thrombus can form, and the blood can clot that valve and make it dysfunctional, stenotic, and not functional at all, or it can clot completely and lead to the death of the patient. We tend to keep these INRs in the range of 3 to 3.5, a little bit higher than the mitral position. It can last forever. In all honesty, I have never seen it last forever in a tricuspid position and on the patient. The one to the right hand of the screen is an example of a bioprosthetic valve. It's made from a stented material on which loaded either bovine pericardium that was treated in shape to make a one-way valve, or the leaflets of the aortic valve of a pig that were basically loaded on the stent. They both have the same performance. The problem with this valve, it doesn't last forever. And in the tricuspid position, again, this valve is not designed for tricuspid position. It's not designed for the pressure gradients that's seen on the right side, but that's what we have available. The ability for that valve to stay and not thrombose for a long time is not known. And on the left side of the heart, it lasts, depending on the age of the patient, between 5 to 15 years. The younger you are, the faster you chew that valve. The older you are, the longer that valve lasts. What is our current approach at the University of Kentucky? We usually give time for the septic emboli in the lung to resolve completely. And I'm talking here about our approach for a pure tricuspid endocarditis. I'm not going to touch on the combined left and right endocarditis. We allow the septic emboli to resolve. If a patient presents to us, his lungs full of septic emboli, that patient will not be considered for surgery. Can every patient survive that? Some patients don't, but these patients, it's futile to offer them surgery, and we don't offer them surgery. We're not going to change the natural course of the disease. What's surprising, you'll see a very sick patient in septic shock with lungs full of septic emboli, yet they can survive, because most of these patients that we're seeing are young, and you always can bank on young age. Second is we put a lot of emphasis on treating the substance disorder, use disorder, because if the patient is going to keep on using whatever you do for them, they're going to come back and need another treatment. And having done tricuspid valve surgery on the same patient 3 and 4 times during the same year in the past, you realize how tough it is to kind of deny patient surgery when they're not adhering to their rehab, but I think that's the right approach for it. We manage, after the patient septic emboli have resolved, substance use disorder has been addressed, the leftover tricuspid disease becomes a chronic regurgitation problem, and we manage that as chronic tricuspid regurgitation. We intervene. We follow the patient closely with a repeated echo, and we intervene. When there is an evidence of early right ventricular deterioration. So if there is increase in the right ventricular diameter, or early reduction in the right ventricular function, then we intervene. And most of the intervention becomes a tricuspid valve replacement. We repair if possible. That's the priority. We'll spend some time in the operating room trying to repair and patch. But in our experience, these cases, the infection eats so much of the valve. Most of the time, you're going to have to repair. There are certain techniques that I don't have the time to go over that you can use in order not to replace. But in our experience, that has not been the case. Thank you very much again for the organizer of this webinar. And if you have any question, we'll be happy to take it.
Thank you, Dr. Retta. I've written a bunch of questions down for you as well. That was a very informative talk, and we appreciate your perspective from a surgical perspective for tricuspid endocarditis. Our final presentation prior to our Q&A, we're going to adjust a little bit. Is from Dr. Gurley. Dr. Gurley is an interventional cardiologist and our current director of the Structural Heart Program and Cardiac Innovation. His practice includes the full variety of structural heart pathology. He completed his medical training at the Ohio State University, as well the College of Medicine and Public Health. So we do appreciate you taking the time to not be watching the game and participating with us. He then completed his residency at Northeastern Ohio University affiliated hospitals in Canton. He later successfully completed his fellowship training at the University of Kentucky, and he's currently triple board certified with the American Board of Internal Medicine, Cardiology, and Interventional Cardiology. He is an integral part of our MDET, or multidisciplinary endocarditis meetings, and is here to provide an interventional cardiology perspective on the management of tricuspid valve endocarditis. Welcome, Dr. Gurley.
Thank you, Dr. London.
So we are going to be opening it up for a question and answer session now. I do want to start with Dr. Gurley. The approach for endocarditis, especially right-sided endocarditis, has changed over the last few years, as we have talked about already. What do you feel the interventional cardiology role is for the treatment of endocarditis, especially right-sided lesions?
You know, that's a very difficult question because we really don't know. And we have the ability to do procedures, but what we haven't learned yet is when we should intervene, what patients require intervention, who benefits from an intervention. So I can show you beautiful pictures of how we can take an aspiration catheter and remove the vegetations from a tricuspid valve. In fact, we get pretty sophisticated about how we shape our instruments, what kind of equipment we use, how carefully we go after each of the 3 leaflets and make sure we have a full effective debulking. But we still don't understand the risk-benefit ratio, and we don't understand, for example, should we remove a vegetation, typically a Staph aureus vegetation, early to prevent damage to the valve, or should we leave it alone to prevent equipment damage to the valve? Does that answer your question? It's a big I don't know, but we can remove the vegetations. We just don't know if we should and when we should.
I think a point to be looked at is, of those patients that you intervene on, what is the likelihood of preserving some valve tissue to be able to be repaired later on when a surgical intervention for a chronic tricuspid regurgitation is warranted? That would be an interesting point to look at.
Yeah, so I can give you my bias on this. Okay, I think that Staph aureus endocarditis is an aggressive, destructive procedure. I don't think that procedures like angiovac, done carefully and by experienced operators, I don't think that the procedure damages the valve. I think it's the infection that damages the valve. I think it's likely that there will be a certain set of criteria: vegetation, size, activity of infection, where early debulking facilitates antimicrobial therapy. Most of us will agree that right now tricuspid endocarditis is a medical disease, and Dr. Retta, you and I are second and third choices.
Yeah. And unfortunately, there's a push for early surgical intervention, as carried from the left side, because if you look at the way the thinking has changed, it used to be you wait, you clear the blood on the left-sided infection, you wait 6 to 8 weeks on strokes, 4 weeks on a non-hemorrhagic stroke, 8 weeks on on hemorrhagic stroke. Now the push on the left side, and which is the right thing to do, is for early intervention, and it's carried by analogy, and there is a push in every meeting to do early intervention on the tricuspid, which I don't think is the right thing to do.
Yeah, we need data desperately, don't we?
And it used to be that historically, it seemed like there were a lot of surgeons that preferred to do valvectomies, especially in the immediate period when patients were being admitted with tricuspid endocarditis, especially right-sided lesions. Is the analogy for angiovac similar to doing a valvectomy, or are you not leaving the patients with wide open TR every time? Is there a technical ability to just scrape off the infection and leave the actual native tissues that haven't been eroded by infection, so they would have more of a moderate TR and potentially would need surgical intervention at a later date than if you completely resect the valve from a surgical perspective the first time around?
Yeah, I think we'll agree that the goal is infection control is soon as possible. Okay, sooner you get control of a destructive infection, the more likely you are to preserve tricuspid tissue. I would rather live my life with moderate asymptomatic tricuspid regurg than to live my life with tricuspid prosthesis. Okay?
Absolutely, it's a disease by itself. Tricuspid prosthesis in a patient is a disease by itself.
Yeah, it is a disease, and our objective should really be, how do we preserve tricuspid tissue? We see a lot of these patients where the valve is destroyed and it's flail leaflet tissue, and it's not repairable. It never will be, not by surgery or some of the newer transcatheter like TriClip approaches. If there's one piece of information that we need to pursue in the next decade, okay, that's it. Is should we intervene early to preserve the valve? Okay, or does our intervention or surgery destroy the valve?
You know, John, for the viewers, is like, why do we speak about angiovac or catheter-based early intervention? We don't speak about surgery early intervention, like Dr. Long is saying. Why don't we go in and cut the valve out and see? First, to go with surgery, this means you need to put somebody on the heart-lung machine who have lungs full of infection and septic emboli, and that is going to increase the morbidity of the patient significantly, if not the mortality, and requires a lot of times to go on at least VV ECMO. Whereas the attractiveness of a catheter-based intervention is you go in and you're not putting the patient on the heart-lung machine, and they might need to be anticoagulated for a short period of time of the procedure, and you don't need to cut all the valve out. You have a chance of leaving some of the valve material there.
Yes,
Following up on that, Dr. Retta, what would you, if you had a way of designing, and I know there's a TriClip as well as some new studies for some new cryoprosthetic valves specifically for the tricuspid valve, and then we also have mechanical valves for patients who have shown commitment to sobriety, but again, that may be a little bit difficult for patients to think when they're 25 years old that they're going to have to be on Coumadin for the rest of their life, and very consistently so. If you were going to be designing a valve for the tricuspid tricuspid valve, and I know that this is kind of putting you on the spot, but what type of things would be involved in that? What type of considerations when we are using currently mitral valve prosthetics, aortic valve prosthetics for the tricuspid positioning, and so we don't have as much information as you said in your talk, as well as the INR recommendations. And so, if you had a tricuspid valve design, what would be important in designing a bioprosthetic for that particular position?
It has to be a valve that requires minimal or no anticoagulation. Second, it has to be a valve that takes into consideration the high flow, low pressure gradient across that valve, and plus accounts to the turbulence that exists on the right atrial side and the right ventricular side of the valve. And none of the valves on the market account for that. There's the valve that's being trialed, and one of our surgeons here is part of the trial. And the jury is out there. And in all honesty, I don't know much about it. I cannot comment on its design. There has not been, to my knowledge, a lot of work on in transplanting homograft tricuspid valves in that location. But as it stands now, I'm with Dr. Gurley. I'd rather take moderate to severe tricuspid valve regurgitation for life rather than put a prosthesis there.
And I think too, to jump in here, a lot of what we're talking about are procedural interventions and being more aggressive with those. But there's room, as I tried to highlight, to be more aggressive with our medical management. Vancomycin, for example, has been around for decades, and I think the practice has often been, the patient comes in, they have MRSA, endocarditis, they get parked on vancomycin for a week, and then we say, oh, we can't clear their blood, so let's do something to the valve. And there's a fair amount of literature now that these combination therapies do help clear the bacteremia. And if we know that patients can tolerate TR fairly well for a period of time, we know that the risk of further emboli goes down the more time you're on antibiotics. I mean, I think it just makes sense to be more aggressive, and to the point that Dr. Retta and Dr. Gurley have made, what's more risk to the patient, putting them on 2 antibiotics for a few days, or going in and operating on their valve, or doing an angiovac procedure. And I totally agree about this idea that, it creates another disease when you have a tricuspid valve replacement. We don't really have data on what does it do to someone's life expectancy when you're 30 years old and you get a bioprosthetic tricuspid valve replacement. But I think we probably all know that patient's probably not going to live until they're 80, which is what we would expect for a lot of people if they didn't have that. So I definitely think there's room to be more aggressive with the medical therapy. And that's where the team approach is really helpful, because we're constantly communicating and talking about, okay, what can we do? Because you want to make the best decision for the patient in the moment, but you also want to make a decision that's going to be good for them in 5 or 10 years. No,
we do have some literature about the attrition rate and survival rates of tricuspid valve replacement. And as it turns out, bioprosthetic and mechanical probably aren't that different. Okay, they should be chosen based on individual patient characteristics. But in general, those two types of prostheses behave about the same. The problem is the disease in which this condition occurs. Okay, these are often patients with a history of IV drug use, or they're patients with dialysis and a constant source of bacteremia, or implantable electronic devices with endovascular leads. And so that underlying substrate really doesn't go away. So the survival statistics aren't great, okay? And the reoperation rate, if you can get out to 15 years, approaches 30%.
Yeah, Sammy, you are not the usual infectious disease specialist, because in general, infectious disease docs are hesitant to be aggressive with antibiotics.
I agree. I mean, I think it's been hard at times to convince colleagues that that taking this aggressive approach makes more sense. But again, like I was saying, it's what's more what's going to be more harmful, an additional antibiotic or a big invasive procedure. And I think to your point, Dr. Gurley, there is that data, but a lot of it is in generally older patients. And
Correct.
so
Correct.
we don't,
Correct.
we're,
And for
I mean,
other disease process, not for this disease.
yeah. And I mean, you saw our study, the median age is 34. So, I mean, half our patients are under that. So it's a big deal. And we have a lot of young women too. And then we have to navigate, are they going to be on Coumadin? Do they want to have a family? And we have to talk, we talk with patients about all these things. I don't think those conversations are happening, universally, but there's a lot to consider. These, as you said, these are big decisions that will impact the patient for the rest of their life. So.
And just to piggyback on that, Dr. Al-Zalati, you had mentioned that there is this is essentially a chronic disease for these patients, and if you can get them into more of a chronic state before you do an intervention, that's always ideal. But amongst the patients that have an intervention, you said 25% of them don't follow up, 25% of them will actually have patient-directed discharge. Is the multidisciplinary approach to endocarditis, do you feel that there's a lot of room for growth so that we can capture these patients back? And how do you address that in our multidisciplinary team so that we can get these patients that are leaving, 25% of the patients are leaving, it's difficult to put a mechanical valve in them if they can't even come back for a follow-up. So how have we addressed that?
Yeah, it's a great question. And I should say it's not quite a quarter of patients that have a procedure. That's just a quarter of all comers, but we still want to follow those people. So, the ways we try to address it are, if we see a patient and we have any red flags, this is someone who might leave, we try to make recommendations for oral antibiotics that patient can receive on discharge. There's lots of data now that shows, even though it's maybe not ideal, that getting oral antibiotics when you leave as a patient-directed discharge reduces your mortality. So we try to do that. We have a nurse who we make sure we have a contact number for the patient. We try to reach out and connect with them. But one of the issues is, as I'm sure people who work at large centers see all the time, is that our patients come from all over the state. We have patients from West Virginia, Tennessee, Ohio. So these patients can be 3-4 hours away. They don't have transportation. So, one of my hopes is that we would be able to develop more of a network with some of the community hospitals and other hospitals within our region so that, and maybe this is a patient where they can follow up with someone locally. And if they need to reach out to us, we can provide some guidance, virtually or over the phone. I really think that trying to have some more community education, connections with the community can help, because we can't bring everybody here. It's not feasible. We have lots of other patients with other diseases that need to be at our center. So trying to do a better job of helping these patients and helping them, further stay closer to home.
Okay. And you mentioned that multidisciplinary endocarditis meetings, as we're all part of them, and the fact that there actually has decreased the mortality is not only 30 days, 90 days, and even 1 year. You've shown that in a lot of the literature that has been published. It seems to me that the European Society of Cardiology, the European Heart Academy, they are all making class 1 recommendations for a multidisciplinary approach to endocarditis. I know that each one of us in our own individual ways has tried to, especially you, Dr. Al-Zalati, create these centers of excellence or endocarditis, or umbrella thereof, a certification program. What do you think the main hesitancy, or why hasn't it been accepted in the societies in the United States, if it has already been recommended as a class 1 recommendation to have these multidisciplinary endocarditis teams and team approach for endocarditis?
Yeah, it's a great question. I think the adoption has been slow in part because 2015, when the last iteration of the American Heart Association endocarditis guidelines came out, they didn't really talk about this topic. And so I think that contributed in part to some of the delay. I think one of the challenges is that a lot of the work that we do is not reimbursed. So we spend a lot of time communicating, coordinating with each other, all these different providers on a meeting, on a call, but we can't really bill for that, even though it takes a lot of effort. We know it improves patient outcomes. our system is just really not set up to value that kind of work. So I think that's been a big hurdle, is that you try and pitch this to a hospital leadership or to your department leadership, and it's like, well, who's going to pay for this? Who's going to pay for our time? And I think that's a big challenge, unfortunately. And you're starting to, like you said, there's more of these societies are starting to make the recommendation, but I continue to foresee there will be challenges for providers getting these teams off the ground until there's some acknowledgement that from a reimbursement standpoint that, hey, this work has value. So I think there's got to be some way to tie it to either performance metrics or reimbursement. Otherwise, I think we're still going to see some struggles with getting these teams off the ground.
I think it's very, very important as we take this project forward. First of all, we have to answer some of those fundamental medical questions, right, Sammy? Like, tell me, Sammy, what vegetation is not going to respond promptly to antimicrobial? Which one should I treat? You have to tell me that. But more importantly, tricuspid valve endocarditis needs to quit being an orphan disease, and it needs to become a mainstream disease. And we're going to have to reach out to our state and local governments to make that recognition, because these patients who even have opioid-related endocarditis, they look like us, okay? They come from small towns, and
they are young.
Patients with pacemakers and dialysis catheters that get endocarditis. These people look like us and our kids, okay? And we need to not push this disease into the fringe, but it has to come mainstream and become a mainstream medical condition that we look at the same way that we do coronary artery disease or any other disease that has robust guidelines and robust treatment algorithms. So we're going to need government help to bring this into the mainstream, and we're going to need professional society help. But Sammy, you and Dr. London, you are leading the way, okay? And we can make it happen.
Well, Dr. Gurley, that's a great segue. Unfortunately, we're running out of time, but I think destigmatizing this disease is going to have to be on the forefront. Just like anything associated with the opioid epidemic, it actually is affecting everyone. And so being able to make that mainstream so that we're dealing with the disease as a team, I think is the best approach, as we've seen here. Dr. Retta, Dr. Gurley, Dr. Eldelati, we very much appreciate your time and taking this time away from your families to be here with us and discuss this important topic. Hopefully we'll have more opportunities in the future so that we can continue to grow and evolve our treatment strategies as well as taking care of our patients. Thank you very much again, and thank you, International College of Surgeons, for giving us this opportunity to bring our work to light and have all of these wonderful people here to talk about endocarditis.
Thanks, everybody.
Thanks.